reality. Thank you very much, Isabelle.
And I will focus my talk today on the outcome of ovarian tissue freezing, so something a little bit different. And before talking about the clinical reality of the outcome of this technique, I would like to come back a little bit about the other reality, which is the oncological reality. As we already discussed this morning, there is and as you know probably, there is an increase in the incidence of cancer worldwide, and it has been demonstrated by this recent study who evaluate the incidence of cancer in the world with an increase of around 28% of the incidence of cancer. Of course, there is a lot of demographic reason for that, but there is also an increase in incidence of young populations who are diagnosed with cancer. Fortunately, as you can see, I will try to use this one here. Here, it's not easy. Fortunately, there is also an increase in the survival. Here, they report the difference in the mortality with time. And you can see in green and blue the cancer with a significant reduce in mortality, and a lot of them concern actually young population. So quality of life become really an important issue. And we already discussed also about this demographic reality, which is the increase in the age of the first child in a woman, who increased about 3 to 5 years according to the country during these last 2 decades. And actually the consequence of that is that more and more patients are diagnosed with cancer before complete their family project or even having their first children. And as more have shown, that actually fertility is one of the priority of this young woman. So, and we have also discussed this decrease in the fertility potential of this young population treated for cancer, and this has been well shown by this recent data of the group of Anderson, who show that cancer survivors have a 38% less chance to be pregnant. This is also a mix of reasons, and not only the premature ovarian failure occurring after cancer treatment, but it's also a reality we have to face. So what we can do for these patients, of course, we can preserve their fertility before the treatment. The best way would be to reduce the gonadotoxicity and allow them to restore normal ovarian function after treatment. This is the best, but it's not easy. We can protect the ovary during irradiation, or adapt the chemotherapy regimen, or using some pharmacological protection, but all these techniques have limitation. And so in practice, what we do usually is to cryopreserve the gamete. As you know, the established procedure is to cryopreserve the oocyte and the embryo, but we need to have time for stimulation in these cases. And so cryopreservation of ovarian tissue constitutes often an interesting alternative, especially so for patients who have no time for stimulation. Of course, the young patients, and it's the only option in prepubertal patients. And it's also a good option for those who have started the chemotherapy. We have a lot of patients, for example, for hematological disease, who started with a low-risk chemotherapy regimen, like IBVD, for example. There is no reason for them to have fertility preservation procedure. But then if they don't answer to this treatment, response is not, it's not enough. They go on with a high-risk treatment, and then we can preserve the fertility using this technique at that time. So in all cases, when we propose to cryopreserve the ovarian tissue, the first thing is to, of course, balance the risk and the benefit of the technique. The benefit is the fertility restoration, and it's like sound like a logical, but there is also debate about the fact that we can use it for restore endocrine function. At present, I think it should be focused on fertility preservation. And the risk who have been considered, you can see that there is several risks. That is the risk of premature ovarian function. After the treatment, we have to be sure that it's important to do it, and we don't do it for nothing, because also we remove a part of the ovary. So if the risk of infertility after treatment is low, you may increase this risk and be more harmful than benefic. The surgery, of course. The recurrence of the disease, I talk here about the risk of retransmission of the disease by the graft. And we have discussed that this morning also, of course, the possibility to have a pregnancy after the treatment. This is something we can discuss at that time already when we know the kind of treatment they will receive. So in our center, we actually started this program in 1999 and have more than 400 patients who cryopreserve the tissue now. And you can see that the indications are quite the same as in the general literature, with a third of patients who have hematological disease, 12% benign disease. We have quite a lot of patients with benign disease, which is immunological disease, hematological benign disease, things like this. And around 60% have solid tumor. And you can see in the left graph that most of them are breast cancer. But actually, now these incidents of breast cancer who perform ovarian tissue cryopreservation decrease dramatically, because we use now oocyte cryopreservation and not ovarian tissue cryopreservation anymore for these patients, except for a specific reason. So it is important, if we want to increase the success rate of the procedure, to start with the good patient selection at the beginning, and also the good technique of cryopreservation. So to cryopreserve the tissue, we can do ovarian biopsy or oophorectomy, and actually the tissue can be transported up to 24 hours. We don't use 24 hours transplantation transport in Belgium because it's a small country, but it can be 24 hours in large country. And actually the established technique now to freeze the tissue is the slow freezing technique and long-term storage in liquid nitrogen. So biopsy versus oophorectomy, it's a debate, and actually in our center we perform biopsy in adult patients and oophorectomy in children. Why? Because we want to keep both ovary in case of the patients recover normal ovarian function. We think that it's maybe better to have both ovary to have a spontaneous pregnancy. And most importantly is the possibility to transplant the tissue back on both ovarian sites, because at present what we observe is that the follicular restoration is the best at the ovarian site when we transplant the tissue. And also we have less risk of damage on the contralateral, of loss of fertility if they have damage on the contralateral ovary in case of oophorectomy. It happens that the patients restore natural ovarian function and then have an issue with the remain ovary, and so you induce the premature ovarian failure. So we are more comfortable with keeping both ovary for these patients. And also because actually for all the patients we take one ovary, we never transplant back the whole ovary, the whole material. And in the literature you can see here that for the transplanted, for the patients who have one ovary are removed, around 45% of the tissue is actually used for transplantation. So how we restore the ovarian function? As I told you, it's only the graft who is available to restore ovarian function in these patients. So at the beginning we do a two-step laparoscopy, but now most of the procedure are done with one-step laparoscopy. And we choose usually as much as possible the ovarian site. Because usually, of course, the patients are in premature ovarian failure, the remaining ovary are atrophic. We don't have a lot of place on the ovarian site, so we use also the peritoneal site to complete and put enough materials to ensure the ovarian function restoration. At the beginning, we use also the subcutaneous site. We observe a good, follicular development on this site, but as we never have a pregnancy for this site, we don't use it anymore. So this is an example of the ovarian function restoration after graft. You can see here in blue the FSH level. So at the beginning it's increasing because, oh no, I will not use it. So at the beginning it's increased because we stopped the hormonal replacement therapy, and then we have a rapid decrease in the FSH level, which is actually reached the premenopausal level, and the patient starts to ovulate after 5 months. She gets pregnancy, but unfortunately miscarriage in these cases. And then after almost 2 years, the FSH levels start to be up and down, and we decided to regraft, to do a second transplantation. And then after that, she has 2 spontaneous pregnancy. And the ovarian function was the ovary was functioning for more than 8 years, and she takes pills to have no more children after that. So it can be a very long ovarian function restoration, and this is really an advantage in young patients. You can have more than 1 children actually. And she was 24 years old at the time of the cryopreservation procedure, and already received 6 cycles of ABVD. So not a problem for young patients to have a first low gonadotoxic treatment before. So up till now, for those who have at least 5 months of follow-up, we have 16 patients who have been grafted. And you can see that 5 of them have babies of 1 or 2 children already. 4 fail to succeed. So all of them restore ovarian function except 1. But 4 of them did not succeed to have a live birth. 2 stopped the conception project, and 5 is ongoing in the follow-up, so we hope they will have a pregnancy soon. 1 is recently, just 1 week ago, we just learned that she has a spontaneous pregnancy. So if we look at the patients who have at least 1 year of follow-up, these 11 patients, we have 5 of them get live birth, so it's quite good. So in the literature, there is a recent review of 318 patients who have ovarian tissue transplantations, and you can see that ovarian function restoration occur in 95% of the cases, which we observe also. And from those who have conception data available, 170 women, 40% of them actually conceived and have at least 1 baby, and half of them was spontaneous pregnancy. So, there is, of course, a factor that are important for the future success rate of the procedure, and one of the most important factors is the age. And in the general study, we observe an increase in the success rate when the patients were young at the age of cryopreservation. And recently, we do a review of the literature, also focusing on the patients who have less than 21 years old, and actually find only 18 patients who have been transplanted when they have when they reach adult age, but have less than 21 years old at the time of cryopreservation. 94% of them restore ovarian function. That is the same than in adults. Out of the 16 who try to get pregnant, 11 of them have a pregnancy and 9 out of 16 a live birth, at least one. So that means live birth rate per patient reach in this group of patients 56%, which is probably more than in adult. Only 5 patients have less than 15 years old, and 2 were transplanted for pubertal induction, 3 for fertility restoration. 2 of them have live births also. So can we transport that result in adult in very young patients based on the data we have? Actually, we don't have enough data to answer this question. We know that there is a lot of difference in prepubertal ovary and adult ovary. Of course, you have more follicles, that's a good point, but we have also difference in the diameters of the primordial and transitory follicles, also diameter of the oocyte change. When we look at the experimental data, the oocyte from prepubertal animals or even human grow slowly in culture. You have more abnormal follicles and lower developmental competence in animal study also. Here you have difference in the tissue according to the age. 9-month-old patients up to 15 years old patients, and you can see already in these young patients the huge difference in the follicular density, and most of the follicles are actually lost by atresia process, not because they start to grow. So there is a huge selection of the follicles during the prepubertal age, and we don't know at present what's happened if we transplanted this kind of ovary back to an adult patient when we skip all this period of selection. Actually, there is only 2 reports of young patients who have been cryopreserved the tissue when they were children and transplanted back at adults. These patients have 13 years old at the time of cryopreservation, premenarchal patient, and this one have 9 years old. So prepubertal patients, but we don't have any data on very young patients. So cryopreservation of ovarian tissue offers also the possibility to collect the oocyte, ex vivo collection of the oocyte during the procedure. We can do it by puncturing the ovary when it's arrived in the lab, and also try to find this oocyte cumulus complex in the main medulla when we finish the dissection. But actually, the maturation rate, according to the literature, vary from less than 20 to 60%. Most of the reports show a lower maturation rate than the classical IVM procedure, which is logical because we take this oocyte at any time of the cycle without any even short stimulation. And also there is maybe an impact of the transport, which is at 4 degrees, not very good for this oocyte. And actually we don't know yet also the ability of this oocyte to get pregnancy, because there is only 3 live births reported using this ex vivo IVM oocyte. So it's a technique that should be more investigated. It's not invasive for the patients. We do everything in the lab, but we need more data on this. So there is room for improvement of the technique, of course, and there is a lot of research on this topic, which can try to improve the vascularization after graft to reduce the ischemic process, because we lose a lot of follicles during this ischemic time after transplantation. But actually, there is a lot of experimental study, but nothing that can be used in clinical practice from now. We can reduce the follicular activation, try to reduce the follicular activation, which is also a big issue when you transplant the tissue, and you can lose a lot of follicles at the beginning of the graft due to that. Improve the technique. A lot of also centers start to vitrify the tissue, but we have no sufficient data now to know which is the best technique. And work also on the site of transplantation. I told you that ovarian site, it's probably the best, but we need also more data on this. The last issue is the risk of retransmission of the disease after graft. You can see here in red the disease that are considered at high risk, and inside there is leukemia patient, which is the most problematic patients, and also a big issue because we have a lot of leukemia children who perform ovarian tissue cryopreservation, and actually we don't know what to do with this tissue now. We need more sensitive technique to detect the neoplastic cells in the tissue. And at present, what we do with this patient is wait for the first line chemotherapy before collecting the ovary, but we need also more data to know if it's sufficiently safe to use this. But there is one patient who have, this is the transplantation of ovarian tissue when in a leukemia survival patient. This is the first case. They use different technique to evaluate the cell contamination before grafting with xenograft in mice, molecular technique, fish histology, and so on. And it was negative, so they decided to graft, and the patients have a baby, and did not have a recurrence of the disease. But it's a big issue still now. Of course, we have alternative. In the future, I hope for these patients, like follicular culture system, artificial ovary, or things that can be developed to use this tissue in a safe manner. So finally, at conclusion, I will say that now several thousand of patients underwent the procedure worldwide, and actually we miss of register of the patients who have been transplanted and the outcomes. So there is big center who provide the data, but we don't know really the reality of that to answer the title. Ovarian tissue transplantation is efficient to restore ovarian function in more than 90% of the cases. This is well demonstrated. And fertility was obtained in restoration of fertility was achieved in 25 to 50% of the cases according to the center. More or less 40% of them have a baby, even after our first-line chemotherapy. It appears to be safe. There is no recurrence of the disease now who has been reported in the literature due to this disease. Age at ovarian tissue cryopreservation is crucial parameters, as well as the follicular density for the success rate. And actually the great advantage is that the patients can get spontaneous pregnancy after that, and in more than one children in some cases. And there is up to 3 babies who have been obtained with one graft in the literature. At the retopic site, I mean subcutaneous site, has not been proved to be efficient, and the other advantages can be associated to ex vivo IVM. So thank you very much.